Welcome back to Medicine Deconstructed. I'm your host, Dr. Jay Rutland. I have talked many things on this channel. One thing I haven't talked a whole lot about is lung cancer. We're gonna talk about this right now. And I want you to remember, this is not medical advice. Medical advice comes from your doctor. Lung cancer represents 13% of all cancers. When you break lung cancer down further, we identify it by either entitling it small cell lung cancer or non-small cell lung cancer. This is basically the way the cells look under a microscope. But let's talk about non-small cell lung cancer. The reason we are shedding light on this is due to individuals who have never smoked being diagnosed. There are three main types of non-small cell lung cancer. There's adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Again, how the cells look and stain under the microscope is how we title this cancer. My mother-in-law and my Iowa mom were both diagnosed with non-small cell lung cancer. Luckily, it was early enough where they've been fine. But when you look at non-small cell lung cancer in general, the 5-year survival rate overall is 17.4%. This means that only 17 out of 100 people diagnosed with non-small cell lung cancer are alive within 5 years. What does that tell you? Typically, people present late stage. You see, when you diagnose cancer, we want to sort out how to score it, the stage. The higher the stage, the worse the prognosis. And the higher the stage, the different the management. We base stage essentially on the size of the tumor and the location of tumor cells in local or more distant lymph nodes, or more distant and different organs. Stage 4 is outside of the lung, perhaps in the pleural space if an effusion is present, or even in the bones and the brain. This obviously has a worse prognosis. I know the question is, how do I know? Well, the scary thing is you don't. The symptoms are cough, hemoptysis, which is coughing up blood, dyspepsia, and chest pain. Dyspepsia is like this GI pain. The way to diagnose or even understand if people have the potential is by doing a chest x-ray or a CT scan. As a pulmonologist, I'm always looking for an excuse to do a high-resolution chest CT on my patients. Part of my reasoning is to screen for lung cancer. One of the issues with lung cancer radiographic screening is we only recommend it to individuals who are aged 50 to 80 with a 15-pack year history of smoking. We may see a lung nodule, again, any well-circumscribed soft tissue that's less than 3 centimeters in size, or a lung mass, which is greater than 3 centimeters in size, along with lymphadenopathy, which are big lymph nodes, in the mediastinal area. These are in the chest, and or people with pleural effusions. I would then either biopsy the nodule or the mass with my bronchoscope or needle biopsy, or biopsy the lymph node or drain the pleural effusion looking for cancer cells. I need the tissue to characterize a type of cancer and to understand the genetics of the cell for potential therapeutic targets. We manage cancer with surgery, chemotherapy, radiation, and targeted therapies. Radiation and surgery are typically for early stage lung cancer, say stage 2 or earlier. We may combine therapies, but targeted therapies are being rapidly advanced. We look at the receptors on the membranes of these cancer cells and or look at the genetics to understand if there are proteins we can bind to that are going to inhibit the growth of these cancer cells. It can get complicated, but your physician should be able to communicate to you why certain therapies are selected. If you want to know more about the specific of therapies for non-small cell lung cancer, we'll talk about that on a future episode. But for now, I want to say thank you for joining Medicine Deconstructed, and I'll see you next time.